Welcome back, listeners, to another episode of The Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist from Dallas, Texas. Today, we have a very special episode recounting the highlights from the American College of Cardiology 2023 conference. I'm joined by a couple of special guests as well. Why don't y'all introduce yourselves?
Hi, everyone. I'm Anam Waheed. I am currently an advanced cardiovascular imaging fellow at Brigham and Women's Hospital, graduating this July, and then I'm going to be headed to MedStar Washington Hospital Center. Thank you so much for having me, and I'm super excited to be here with you.
Phenomenal. Thank you for joining us, Anam. All right. And how about you, Nidhi?
Thanks, Praveen. I am Nidhi Madan. I'm a structural interventional cardiologist working at Nebraska Methodist Hospital in Omaha, Nebraska.
Awesome. Anam and Nidhi, thank you so much for joining us on the podcast. Why don't we begin by talking about some of the latest research and insights that were presented about cardiac CT at the ACC conference? Nidhi, why don't you start us off?
Sounds great, Praveen. So one of the talks that caught my attention was given by Dr. Renee Bullock-Palmer on calcium scoring and prognosis. We know that the prognostic value of calcium scoring has been widely established, and Dr. Palmer's talk highlighted the usefulness of this tool in refining cardiovascular risk in patients with low to intermediate risk of coronary artery disease or intermediate risk ASCVD scores.
Yeah, that's right, Nidhi. Dr. Palmer also discussed how hybrid imaging with the addition of coronary artery calcium scoring with SPECT-CT and PET-CT provides incremental prognostic value to functional testing. She also emphasized that the importance of reviewing those non-gated chest CTs to assess for the presence of coronary artery calcification.
Yes, that's such an easily accessible way to get additive insight into your patient's risk and prognosis. I found it really interesting that Dr. Palmer also spoke about the validation of the prognostic significance of coronary artery calcium in young people, aged 30 to 49 years, without known cardiovascular disease. Presence of coronary artery calcium was found to be associated with higher levels of major adverse cardiovascular events and myocardial infarction in this population. And severe coronary artery calcium increased all hazardous outcomes, including death. Dr. Palmer also highlighted that it's not only plaque amount, but also plaque characteristics such as plaque density that are of prognostic value.
Yes, that is a great point, Anam. In fact, the 2022 JACC review commented on the role of that plaque density in calcium scoring. Interestingly, calcium density was found to be inversely associated with lesion vulnerability. That's to say, calcium densities of less than 1,000 Hounsfield units were associated with a lower risk of acute coronary syndromes, independent of other risk factors.
You know, another talk that I thought was really educational and insightful was Dr. Michelle Williams' talk on coronary plaque analysis to drive management decisions. She reminded us that coronary artery disease can be present in people without coronary calcium and highlighted the new CADRADS 2.0 coronary CTA reporting guidelines as a way to help communicate results of the coronary CTA and next steps.
Yeah, interestingly, Dr. Williams also mentioned that when compared to the prior CADRADS guidelines, the CADRADS 2.0 provides a quantitative assessment of plaque in addition to categorization of stenosis severity, and also provides the referring provider with recommended next steps. Plaque quantification can be done by a visual assessment, by the segment involvement score, or quantitatively using a calcium score. It categorizes plaque from P1, which is a very small amount of plaque, to P4, which is a very extensive amount of plaque, and helps guide preventative therapies.
Yeah, plaque quantification is certainly a hot topic, and there is even more to come in the future. More work is being done on quantitative assessment of plaque characteristics. Based on attenuation, we can assess plaque subtype, quantitative total volume, as well as quantitative assessment of its different subtypes. For example, low attenuation plaque has been found to be an independent predictor of major adverse cardiovascular events. Patients with greater than 4% of low attenuation plaque were 5 times more likely to suffer an MI. Additionally, the rapid CCTA study out of England also showed us that this type of plaque characterization helps identify high-risk patients with acute chest pain, not just the stable chest pain population.
That is so interesting, and hopefully, we'll have more and more tools at our disposal to refine our patients' risk. Another talk I found very insightful was Dr. Christina Fuss's talk on CT planning for tricuspid valve interventions. As a fellow, we don't really see a lot of these, so it was amazing to have an expert go through things systematically. She emphasized that imaging the tricuspid valve is tricky, as we all know. The annulus itself is difficult to trace with coronaries running in the interventricular groove. There may be pre existing things on the right side of the heart, such as pacemakers and ICD leads. And the tricuspid valve annulus also changes in size with the volume status of the patient.
That is so right, Anam. And ideally, we want our patients in a compensated, hydrated state. Dr. Fuss highlighted that to ensure adequate right sided opacification, a triphasic injection is used, where the first phase of the injection is 60 to 70% contrast and the rest is saline. The second phase is about 25 to 30% contrast and the rest is saline. And then this is followed by a saline only injection in the third phase. She commented on the measurements that are important for planning a transcatheter tricuspid valve procedure. These include tricuspid annular dimension and morphology, course and distance of the RCA, the right coronary artery, from the annulus and tricuspid valve, the function of the right ventricle, and any abnormalities of subvalvular anatomy.
Yeah, Dr. Fuss went on to describe that if pacemaker leads are present, which is often the case in these patients with tricuspid pathology, it's important to assess leaflet mobility, any leaflet tethering that may be present, as well as the angle, the height, and the area of that leaflet tenting. We also should assess for the risk of RV-OT obstruction and try to predict the optimal fluoroscopic projections for device implantation. And this is quite reminiscent of the mitral valve space, too. In addition, we should try to assess venous anatomy, venous patency, and any cardiovascular anomalies that might be of import for vascular access or simply planning procedure itself.
Yeah, it was such an educational talk. I, for one, am going to be going back to that one and listening to it again. Another thing a lot of us in the cardiac CT world are excited about is photon counting CT, and Dr. Eric Williamson actually talked about it at the conference. He highlighted its advantages for patient imaging. There is increased spatial resolution, there is reduced electronic noise, lower radiation dose, decreased metal artifact, and decreased beam hardening artifacts. There is also increased spatial resolution, which leads to improvement in imaging in patients with calcifications and stents. What's not to like?
Certainly very true, Anam. And he further explained the physics principles of photon counting CT. Without going into a lot of complex detail about it, in photon counting CT, we can define the energy at which we want the image to be produced. We can set our energy to be above the energy of electronic noise and in turn reduce the image noise.
Yeah, he really emphasized that this is a paradigm shift from the prior CTs that we have known. These are no longer the energy integrating detectors, but rather photon counting detectors that can measure the energy of each individual photon. In doing so, we can weight the photons equally instead of weighting them preferentially for certain energies of photons. This helps, as you had mentioned, Anam, improve the signal to noise ratio, reduce the overall noise, get that super high spatial resolution pictures that I'm sure many of our audience has seen, all at the benefit of having less artifacts and overall reduced radiation dose.
That's right. And another really interesting talk relevant to our clinical practice was Dr. Blankstein's talk on the use of coronary CTA in the evaluation of patients with stable angina. He highlighted the guideline-based recommendations for the use of coronary CTA in the evaluation of patients with stable angina and discussed the importance of appropriate patient selection, emphasizing that it is most useful in patients with intermediate pre-test probability of obstructive coronary artery disease. The presence of significant stenosis can then guide further management decisions.
That's right, Nidhi. He also emphasized the importance of careful interpretations of the results of the coronary CTA, noting that in the current real world scenario, there can be significant variability in interpretation among different readers. And so he recommended that coronary CTAs should be read by experienced readers who are familiar with the technique and its limitations. He also talked about the importance of understanding the limitations of coronary CTA, including its inability to assess microvascular disease, its limited ability to assess functional significance, and the potential for false positives and negatives.
Moving into the physiology world, let's talk about Dr. Andrew Choi's talk on FFRCT, which was certainly super compelling and very relevant to many of us coronary imagers in clinical practice. He explained in a comprehensive way the technology behind FFRCT, which relies on a 3D anatomical model of the coronary tree that's derived from the CTA images. The principles of computational fluid dynamics are then applied to simulate physiologic coronary flow under conditions of hyperemia. Coronary flow and pressure can then be calculated in different parts of the coronary tree, and voila, we can have these FFRCT calculations.
Exactly. And Dr. Choi further explained that an FFRCT of greater than 0.8 is considered normal. FFRCT of less than or equal to 0.75 is considered abnormal. And an FFRCT of in between those two numbers, 0.76 to zero point 0.8, is considered borderline. He highlights that the guidelines recommend the use of FFRCT to evaluate lesions with 30 to 90% stenosis. CADRAD's 3 to 4A categories to assess for lesion-specific ischemia and guide our decision making.
And he also highlighted that the advantages of FFRCT are its high negative predictive value and avoidance of multiple tests. He points out that the major benefit of FFRCT is derived from reducing the number of invasive coronary angiograms with non-obstructive disease. The disadvantages are that we can only use this technology if image quality is good. It cannot be used in patients with stents, prior CABG, and is not validated for distal vessels.
Awesome. Anam and Nidhi, I think this is a really good recap of the main highlights that we took away on cardiac CT topics at the ACC conference. What I'd like to do now is cut to a conversation that we had with Dr. Andrew Choi about his recap of the conference and the upcoming annual scientific meeting for the Society of Cardiovascular CT. Let's cut to that now.
We are very excited to have Dr. Andrew Choi here with us today. He is an associate professor of medicine and radiology at George Washington University. He's also the co-director of multimodality cardiac imaging. He is a thought leader in cardiovascular imaging and prevention, and is also an editor at JACC Cardiovascular Imaging. We have been fortunate enough to work with him as part of the first committee because he is the board of directors liaison for the first committee. And we're very excited to have you here, Andrew.
Thanks so much, Anam and Nidhi. It's a joy to join this podcast for the first time at the Donut of Destiny. And I really applaud the work that you have been doing, as well as Praveen has been doing, in really leading this podcast into new directions and really helping to teach not only the early career and trainee members, but really all of the members of SCCT and outside of SCCT on what is developing and new in cardiac CT.
Thank you so much. We would not be able to do any of this without your mentorship. We're excited to know what CT related content caught your attention at the ACC annual meeting.
Yeah, so the podcast today, we want to just highlight some of the interesting trends out of ACC 2023. And while we can't really touch upon all of them, I think there are a couple of pertinent things that will be of interest to your listenership. The one that many of us may already know is the Target randomized trial, looking at a new CT-FFR on-site technology, and it's from a company called Kia Medical, for which I have no linkage or disclosures. And to put this in context, I think where we're seeing in the field is to first think about the role of the really interesting and expanded role of CT-FFR in practice. And how does it apply now in stable chest pain? How does it apply for revascularization planning? And if we take a first step for our listeners and just ask, what is the best role for CT-FFR in current practice? It is now a part of the ACC, AHA, SCCT multi-society guidelines, especially for patients in which there's uncertainty regarding symptoms and revascularization. For those patients who have intermediate stenosis, and that's defined as 40 to 90% by the ACC. And then subsequent to that, with linkage with the subsequent CAD-RATS 2.0 that was published last year by the SCCT, for those patients that are at 50 to 90% stenosis, it's probably about 10 to 15% of cases in which CTFFR best applies for our patients. And we still have to make sure we have good image quality while ensuring access and thinking about the costs. And I think in that context, we have a very, very trial-based and very well-validated approach from HeartFlow, but we're seeing a number of new approaches that are emerging. And that's the context for this target randomized trial based out of China. 1,200 patients that had intermediate stenosis at a 30 to 90% threshold, which was very similar to the design of the very initial CTFFR trials from 6 Chinese medical centers. There were similar baseline characteristics for patients that had typical or atypical anginal symptoms. About 69% of the patients in the CTFFR care group had underwent invasive angiography, and about 79% in the standard care group underwent invasive angiography. And what they showed was that they could reduce the proportion of patients that underwent invasive angiography without obstructive disease or requiring intervention in 90 days, but it did increase the revascularization overall for those patients that had on-site CTFFR without improving, but without any particular difference in major adverse cardiovascular events. I think what we note for this, in addition to it being a randomized controlled trial with hard outcomes, is the methodologic differences are interesting to note that are different. What they note is this deep vessel FFR workstation, and they're applying a series of machine learned algorithms, including convolutional neural networks, at each step of the image segmentation process and the feature tracking process, so that they look at using the AI machine learning to look at image brightness and gradients, and then estimating an FFR value and as less than 0.8 or greater than 0.8 based on other conventions. Now, we don't get told, at least in the methodology, of whether it uses the same types of Navier-Stokes equations that are being used by HeartFlow, but at least because they have some trial data that backs up the methodology and approach, we have some reasonable confidence that it's similar. I think the important thing to note for our listeners and also for clinical practice is that this Kia medical approach and the HeartFlow approach are both FDA approved in the United States, and then Kia Medical also notes it has CE mark approval for Europe. And so there's something that I think you may see coming, and we'll have to adjudicate and see how it performs in the real world. I want to point out that also presented at ACC 2023 is an approach from looking at AI and machine learning using a series of quantitative plaque parameters called AI-QCT ischemia. This is from Clearly, and I have to note COI with this, as well as being part of the main author group. There was a study called High Diagnostic Accuracy of AI ischemia in comparison to PET, FFRCT, SPECT, and invasive FFR. And this was a sub-study of Pacific, as you'll recall, was published previously in JACC, JACC imaging, looking at validation of FFRCT against important gold standards of water PET and invasive FFR. Dr. Nick Nurmohamed, who's a research fellow from Amsterdam and George Washington, led this study. And what this looked at was AI-QCT using 37 specific quantitative plaque parameters using AI machine learning, so using also a series of convolutional neural networks, and looking at specific parameters that could try to predict the absence or presence of a functionally significant lesion on CT. And what they had shown was that plaque stenosis and plaque diffuseness were part of the machine learning-based random forest model that was created to be able to predict whether something was FFRCT, was FFR positive or significant or not. The AUC of the AI-QCT was 0.91, and it was similar to FFRCT, similar to water PET. And all the two CT-based approaches outperformed SPECT in comparison to the invasive angiography and invasive FFR standard. One other approach that was touched upon at the meeting, not yet FDA approved, as well as this clearly approach is not yet FDA approved, is using non-invasive FFR estimation using histology validation for using also a number of quantitative plaque parameters to predict whether something is FFR positive or not. And so I think it's interesting to note there are kind of multiple approaches that are coming out through the field. There are at various stages of validation, and I think it'll be up to us to adjudicate what we have, what we apply in practice. One last study I'll note that was also presented at ACC Imaging Highlights is the use of machine learning and deep learning for quantification of coronary calcium. And this is from Peter Slomka, Dan Berman, and Dominique Day, and the lead author was Akash Shanbag from Cedars-Sinai. And I think one trend, and SCCT was part of this, is the use of hybrid SPECT CT imaging and using that imaging to be able to use the CT part to do plaque assessment and coronary calcium assessment. And so what Cedars-Sinai had done is to take this one step further and is to use machine learning to be able to do automatic assessment of the calcium score and did training on a very large internal database with external testing that included almost 10,000 patients. And what they found was that they could have a good concordance with standard approaches. And it may be a way to be able to leverage the SPECT CT approach and to be able to get the calcium score in a very, very quick way. And so I think it speaks to kind of importance of also ongoing importance of plaque assessment and maybe the methodologies that we use, not only from an Agatston gated CT, but also how we leverage non-gated CTs from SPECT CT.
Thank you so much for that incredible insight into the CT-related highlights at the ACC meeting. I think there's definitely a lot of interest in FFR-CT being an effective gatekeeper to the cath lab and a lot of buzz around plaque analysis and assessment. So it will be exciting to see how this field evolves further. We also have the annual scientific meeting, the SCC annual scientific meeting coming up. Are there sessions or science that you are looking forward to at the meeting?
Yeah, the SCCT annual meeting, I think, is going to really be the best yet. And I want to first give a huge kudos and shout out to Dr. Ed Nickel, the president-elect of SCCT, who's been leading the program planning. He's put together, I think, a lot of very innovative ideas, presenting perspective from the United Kingdom and throughout Europe, and also really putting into place some, where are we at the forefront of cardiac CT, while really thinking about the core aspects of cardiac CT that everyone should know. You know, on this theme, thinking about the annual meeting, and also myself being part of the program planning as the chair for the AI machine learning track with colleagues Dominique Day, Michelle Williams, and also Ed Nickel. The pre-program events are outstanding, and there's an expansion in the pre-program events this year. Dr. Leipzig, he's in multiple workshops this year. He has a new workshop that's called Hands on Heart, and it will allow attendees to really think next level about aortic valve planning and TAVI planning, bringing in explanted specimens of aortic valve disease. So I think interesting aortic valve disease pathologies that they're using to guide new developments in the field, and also really reviewing specific complications or challenges that a CT imager might encounter, like bioprosthetic valve degeneration, planning for valve-in-valve, and imaging of Panderson thrombus, so that we really think about lifetime management of a patient that may be at low and intermediate risk getting their first TAVR, and thinking what happens now, not only 2 to 3 years out, but 5, 10, 15 years out. Congenital heart disease has had a special emphasis this spring with a variety of workshops. And I think we're really encourage everybody to participate in as well as possible in that congenital heart disease workshop. It's being led by Dr. Anjali Chalaya, a member of the SCCT board. I want to give also a plug for our AI machine learning workshop led by Dr. Ed Nickel and myself. I think this is really directed at all of you that are listening, not only trainees and early career professionals. It is directed also at healthcare leaders. And you may be an emerging healthcare leader in your environment and have the ability to really bring about positive changes in the healthcare environment. And what we want to teach you is, how can we incorporate incorporate all of these AI machine learning developments, including those that we touched upon at ACC, into your clinical practice. We have a data workshop with James Coots so that you can learn some of the kind of nuts and bolts of how, not only how the programming works, we'll have a little bit on ChatGPT, which is a big part of what's been happening in the field this spring, so that you can have some hands-on experience from James. And he's really a thought leader. He's somebody that guides the governmental leadership of the United Kingdom, so somebody you don't want to miss. And we have small group sessions so that we're going to ask everybody to take what we're calling the Stefan Achenbach mega widget. So an AI tool that does everything, coronaries, flow, P5, looking at the thoracic cavity, something that doesn't exist, but to use that as a model to say, what is the idea if you wanted to apply the right algorithms to develop something in AI, to be able to get validation for it, to think about the economics of it. How do we pay for it? Who pays for it? Where's the funding for AI coming from? Because that will inform what is coming in the field with the FFRCT billing code, as well as one that's at level 3 status for plaque quantification. And understanding the economics of it will help you hopefully try to integrate these technologies into clinical practice. And then thinking about, what is the evidence that we need? What do we need to do to take these and really think about the next level of guidelines? So this AI workshop is directed at you, and we have in the afternoon, we'll help from Eric Williamson, past president, to help guide you also on how you think about this so that you can go back to your institutions and be leaders in your area and region. And we're thankful for all of the industry-based partners that will be participating. And there's a pretty broad range that you can look at on the website.
Thank you, Andrew. I am so excited about the annual scientific meeting, especially about some of the pre-program workshops. I'm trying to take advantage of the fellow in training discount while I can. So to any trainees listening, there's incredible workshops before the annual conference, and you can take advantage of the discounted rates. And just looking forward to meeting everybody in person as well.
Great. Well, let me just highlight a couple of things I want to, just for the main program for all of you. There's dedicated programming for fellows and early careers, an Intro to Cardiac CT bootcamp. Now, for many of you, it may already be old hat because you're leaders in your institutions or in training, but I think it would also be a helpful way to get a different perspective from people from across the country. There's the CCT education and training track. And so every year in the last couple of years, advice from the president to trainees, so Dr. Goshardra, our SCCT president, giving you his perspective, not only as somebody that has his own trainees, but also perspective from the field. So not to be missed. A talk on work-life balance. What is your why? Why do we do this? But also, how do we integrate, especially after COVID, because there's been a lot of challenges in the workforce itself. There's challenges in how you balance family life. And training isn't what it was 100 years ago, where you stayed in the hospital and you were expected to do everything. How do we strike that right balance as leaders in cardiac CT? We're excited in the opening session. There's a new SCCT Clinical Trials Award that will speak to the role of CT in bypass graft planning, revascularization planning from the UK. The Arthur Agatston Award this year is being awarded to Dr. Martha Golati. She will be the first woman in SCCT's history, I think only the second woman after Leslie Shaw, to be receiving a major award for her work in prevention, her work as current president of the American Society of Preventive Cardiology, and of course, her work for the ACC, AHA, SCCT Multi-Society Chest Pain Guideline, for which she was chair, as well as her years of evidence generation and education in the field. I think Dr. Goshardra has invited Dr. Anupam Jaina, who's the Newhouse Professor of Healthcare Policy at Harvard, discussing random acts of medicine and really thinking about some of these economic questions and also how, the model of healthcare going forward. I think the last thing, in addition to TAVR, as we've talked about, AI machine learning, is Trendic technology. The chairs are Emma Chesty from the United Kingdom and Ronan Rubinstein from Israel. Photon counting, spectral imaging, advances in CT scanner automation and strain imaging. I think beyond plaque, beyond flow, I think are the areas of really great interest for trainees and fellow professionals. On the trial front, I think it's been a relatively quiet trial year or guideline year, although there is a new ACCHA SCCT multi-society AUC document that came out last month. But I think the role of plaque as an endpoint in our clinical trials is something under development right now, so that when we think not only in the revascularization end of the spectrum, how do we think about the prevention end of the spectrum, and how do we think about new drug targets using plaque imaging? I'm excited what will be discussed at this meeting.
Yeah, there's some incredible content coming up, and thank you for those insights, Andrew. I'm very excited about these sessions as well.
Well, Anam, Nidhi, I think we'll ask what you're excited about, and I'm really excited to see you all at the meeting.
All right, guys. I think that was an awesome summary of the conference and some really cool things to look forward to in the upcoming annual scientific meeting. Anam and Nidhi, before we close, I want to get a takeaway from you about what you guys are excited about in the future of cardiac CT, not just from these conferences, but for the field in general. Anam, why don't you go ahead?
I think one of the things I'm most excited about is photon counting CT. A lot of our patients for whom coronary CTA is currently not the best test for, we would be able to do coronary CTAs on them because the technology of photon counting CTs is so amazing. I've been seeing some of the images coming on Twitter. I don't have personal experience with it, but it blows my mind how amazing the spatial resolution is.
Yeah, for sure. It's as though we're using nearly a microscope to look into these coronary arteries. There's images out there of the stent frames of 3.5 millimeter stents in these coronary vessels. Absolutely incredible. Totally agree with you, Anam. Nidhi, how about yourself? What are you looking forward to most in this field?
I think there is so much to look forward to in the field of CT at this time. And it's just so fascinating and exciting to see all the areas of our cardiovascular disease benefit from coronary CTs and cardiac CTs in general. The one particular that excites me from my role as a structural interventional cardiologist is its role in planning a lot of our structural valve interventions. And I'm very excited to see this moving forward into our tricuspid valve interventions, which was the prominent area of discussion at the ACC conference as well. And I'm sure there is a lot more to look forward to in the future.
Super cool. Nidhi, Anam, thank you so much for joining us on the podcast. I think this was a really cool recap episode and one that's going to generate quite a bit of excitement about the future of the field.
Thank you so much for having us.
Thank you, Praveen. Thank you, Anam. It's great to be here.
Of course. Thank you all again. And to our listeners, of course, thank you so much for joining in to listen to the podcast. If you like this field, go out there, join the ACC, join the SCCT, come out to our conferences. This is where these conversations are happening. This is where the fringe of the field is, and it is so exciting. Additionally, please rate, review, and subscribe to the podcast. The more interest we get, the more this information gets out there. We love what you guys are doing for us, and we're hoping to continue this podcast into the future of cardiac CT. Once again, this is the Donut of Destiny. Cheers.